venous disorders of the liver مش congenital anomalies أو venous anomalies of the liver vascular disorders of the liver أو venous disorders of the liver 4 حاجات أساسيين البط كياري syndrome الفينو اوكلوزيف ديزيز هيباتيك هيمانجيوما and portal vein thrombosis. انا مش هاخد اكتر من 10 دقائق رابيدلي. فلو احنا خدنا الايميجنج موداليتيز هو عنوان المحاضره ايه بالظبط؟ عنوان المحاضره ايه؟ النيو ايميجنج موداليتيز how can they help in the diagnosis of vascular disorders or venous disorders of the liver. The most important or most new imaging modalities that can be used for diagnosis of vascular disorders of the liver include ultrasound, CT, MRI, and isotopy scan. Ultrasound includes the color Doppler and elastography, the most new investigation tool. MRI includes MRI venography, SCT includes CT venography, and the angiography we will use the venous phase of the angiography, and lastly the isotopy scan for diagnosis of these anomalies or these disorders. We will start by Budd-Chiari syndrome. What is meant by Budd-Chiari syndrome? Simply it is just narrowing or occlusion of one of the hepatic veins or all the hepatic veins or the retrohepatic portion of the IVC, and sometimes the suprahepatic portion of the IVC. This will interfere with the venous drainage of the liver and will result in what we call venous congestion of the liver. It is a very rare entity with non-specific laboratory and clinical findings, and it is missed usually from many physicians, so I will stress on this. The exact etiology is, in most of the cases, will be non-determined, but it may be idiopathic without unknown cause. Polycythemia vera or blood disorder can lead to this anomaly. DVT with extension of the clot from the leg veins to the common hepatic veins, then to the IVC, and lastly to the hepatic veins. Pregnancy may be associated with this disorder. The use of contraceptive pills or drugs, fibrous webs or membranes in the IVC or the hepatic veins, renal tumor, adrenal tumor, HCC, hepatic metastasis that can involve or compress the IVC, renal tumors or adrenal tumors extending to the renal vein, then to the IVC and to the hepatic veins will result in this disorder. We will shift to the most important point in this disease, which is very important for us as radiologists, how to diagnose this entity of liver disease. There are diagnostic findings and helpful or highly suggestive findings. The diagnostic findings include hepatic vein stricture or stenosis, discontinuity between main hepatic vein and IVC, dilated caudate lobe veins, retro or suprahepatic IVC obstruction either by web, stenosis or occlusion, and the highly suggestive findings include diffuse inhomogeneous or mottled hepatic parenchyma, multiple hyperplastic nodules, monophasic Doppler flow in the hepatic veins, and the presence of venous collaterals. I will discuss rapidly every of these diagnostic findings of this. The first is the diagnostic findings, which are very important and very diagnostic. The first is hepatic vein stenosis. This hepatic vein stenosis can be diagnosed easily by ultrasound. This is typical normal hepatic vein, the 3 hepatic veins which are draining into the IVC, and this is the IVC. This is one of the hepatic veins which appears dilated with long segment of structure or stenosis in its continuity with the IVC. This is the hepatic vein stenosis by MRV. You can see here the stenotic segment well delineated by the MRV, and this is by direct venography, puncture of one of the hepatic vein, injection of contrast. You can see here the IVC and the heart, and this is the stenotic segment here, and this is the collaterals. You can see the collaterals and the dilated proximal hepatic veins by direct venography. The second diagnostic item is the discontinuity between main hepatic vein and IVC, or what we call hepatic vein occlusion. This is the ultrasound again of the normal hepatic veins and the retrohepatic portion of the IVC. Here you can see the 3 hepatic veins, the right, middle, and the left, and there is a discontinuity between the IVC and the hepatic vein, denoting hepatic vein occlusion. Again by the MRV, this is the normal 3 hepatic veins, and here this is the discontinuity between the IVC and the hepatic veins, denoting hepatic vein occlusion. And this is the direct venography. You can see here the discontinuity or complete arrest of the contrast, and it does not reach the IVC, denoting hepatic vein occlusion. The third sign is the dilated caudate lobe vein, which is very important and informative and diagnostic finding. This is the caudate lobe which is markedly enlarged, and this is the dilated caudate lobe vein, which when you find, you can easily diagnose Budd-Chiari syndrome. The fourth finding is the retro or suprahepatic IVC obstruction. By any means you can diagnose it. This is the normal IVC by ultrasound. This is the retrohepatic portion of the IVC, and this is the suprahepatic portion. This is the diaphragm. Suprahepatic portion of the IVC. You can see here by ultrasound the retrohepatic portion with short segment of marked stenosis and small web. You can see this is the web hyperechogenic membrane. You can see it easily. This is the IVC of the web by MRV, and this is the again the dilated hepatic veins, proximal. This is the markedly narrow retrohepatic portion of the IVC, and this is the web. This is direct venography. You can see here the IVC structure and the web short segment of marked narrowing before the IVC enters into the heart. We are finished the diagnostic signs. Now we will shift to the highly suggestive finds, where the first is diffuse and homogeneous mottled parenchyma, which usually diagnosed in most of the cases as hepatoma. This is a typical inhomogeneous liver and mottled appearance by CT with multiple hyperechogenic nodules, and the briefly appears hypodense due to the liver congestion, and by the IVC, by the ultrasound, you can see also the presence of multiple nodules and the presence of ascites, which are highly suggestive of Budd-Chiari disease. The second is the multiple regenerative or hyperplastic nodules, which are usually diagnosed by our young colleagues as hepatoma. These are multiple enhanced nodules that can be diagnosed either as hepatoma or hemangioma or whatever, and by ultrasound you can see this regenerating or dysplastic nodule, which is very common in Budd-Chiari disease. The third is the venous collateral. The presence of venous collateral. This is the liver by ultrasound. You can see multiple intrahepatic collaterals, which are seen when they are small. They are called coma-shaped collaterals. But you can see when they are enlarged, you can see them easily, and you can initiate your Doppler and you can see these collaterals easily. This is the MRV. You can see the marked collaterals, which is very important. This is direct venography. You can see the hepatic veins and the markedly dilated intrahepatic collateral, which are very suggestive for the presence of Budd-Chiari syndrome. The last, I think, is the monophasic blood flow in the hepatic veins. You can see here the normal flow of the hepatic veins, which appears as phasic flow, because these hepatic veins are near the heart, so the pulsations of the heart will be transmitted. So you can see this phasic flow, which is nearly approximately similar to the arterial flow. And when there is Budd-Chiari syndrome or obstruction, you can see the phasic flow, monophasic flow, which is very important and very suggestive for the presence of obstruction and very suggestive for the presence of Budd-Chiari syndrome. Lastly, the role of isotope in Budd-Chiari syndrome, you can see the dense appearance in the caudate lobe, and the periphery will appear hypodense and do not will take the contrast the isotope. This is a very important case of interventional technique in treatment of Budd-Chiari syndrome. This is direct venography. You can see the complete occlusion of the hepatic vein, and there is non-opacification of the IPC, and there is balloon dilatation. Still here there is incomplete dilatation, and there is a waste in the balloon, and after complete dilatation you can see there is no waste, and lastly you can see free flow of the contrast, and the problem is solved completely by the interventional technique, and there is no need for the more advanced one, which is called liver transplantation. This is the second entity in my talk today is veno-occlusive disease. It is the obliteration of the central draining veins of the hepatic lobules by an inflammatory and fibrotic process. The problem is not in the main hepatic veins, it is in the central hepatic veins in the hepatic lobule. The hepatic lobule contains the bile duct, hepatic artery, and hepatic venule. The problem occurs in the central veins. This problem is usually due to inflammatory and fibrotic process. It can be caused by drinking of a special type of tea in Asia called Jamaican bush tea, or after chemotherapy in bone marrow transplantation. In bone marrow transplantation, those patients usually take special types of chemotherapy that lead to fibrosis and inflammation of the central hepatic veins. This usually occurs at microscopic level, so the diagnosis is made by liver biopsy and coagulation markers, and there is no rule for diagnostic methods, and the imaging is used to exclude other causes of this abnormal liver function and not to diagnose veno-occlusive disease. The third entity in my talk today is hepatic hemangioma, and I think the imaging features of hepatic hemangioma was covered by my colleague Professor Dr. Ahmed Jalal Sadiq. But here I will stress in some points in hepatic hemangioma which are usually missed by our young colleagues. Hemangioma is the most common benign tumor affecting the liver. Hepatic hemangioma are mesenchymal in origin and usually solitary. Some authorities consider them to be benign congenital hamartoma. Hemangiomas are composed of masses of blood vessels that are atypical or irregular in arrangement and size. The etiology remains unknown. This is a typical case of hepatic hemangioma by ultrasound. You can see this hepatic hemangioma as well-defined hyperechogenic mass related to a blood vessel, like this case of well-defined homogeneously hyperechogenic mass with related blood vessels. One of the points that I wanted to stress on it today is the size of the hepatic hemangioma, and it can enlarge or not. Yes, it can enlarge because some cases or most of the cases of hepatic hemangioma, when bleeding occurs inside this hemangioma, you can see it small, and after few months you can see it very large, and in a third visit you can see it smaller again. There is no problem, and sometimes it disappears completely, and it starts to reappear again and starts to be larger in size, because these are capillary or cavernous spaces, and the hemorrhage can occur, so the size can increase and the size can decrease. And don't miss this point, like this case it was 3 centimeter in 1987. In 1996 it was 6.5 centimeter, so it is enlarged, and in another visit it can be decreased. Hemangioma by ultrasound and Doppler ultrasound in hemangioma you can see just the surrounding blood vessel and no flow in the hemangioma, and you can see what we call a spot pattern, which is multiple color dots inside the hemangioma, which is characteristic for this type of the disease. Hemangioma by CT, you can see the hypodense appearance in non-contrast, and the peripheral nodular enhancement, the closing pattern of iris or closing iris pattern of enhancement. The MRI, as our colleague had said, this is the T1 appears hypo-intense and homogeneously hyper-intense in T2 weighted image, and this is the post-contrast. This is the hypo-intense in T1, and the peripheral nodular enhancement, which increases towards the center of the disease. Here also you can see the peripheral nodular enhancement and the complete filling or centripetal type of enhancement. The angiography is very characteristic in hemangioma. You can see what we call a stippled pattern of enhancement, which is seen in the delayed phase or the venous phase and not in the arterial phase. Lastly, I came to the last item in my talk today, is the portal vein thrombosis. There are many causes for this portal vein thrombosis, as liver cirrhosis, abdominal infections as appendicitis or inflammation of the bowel, abdominal surgeries as splenectomy, which is the most common cause of benign portal vein thrombosis, severe abdominal trauma, blood clotting disorders, umbilical vein catheterization in the young babies, no obvious cause, or idiopathic malignancy, which is a malignant type of portal vein thrombus. Here you can see the total thrombosis of the vein with multiple collaterals anterior to its main stem, and this is a partial thrombosis with still flow in the, and this is a CT. You can see the thrombosed left and right hepatic vein. The most important is how to differentiate between benign thrombus and malignant thrombus. In the benign thrombus, there is no flow in the thrombus, while in the malignant thrombus, it takes the same pattern of the original disease, and you can see the flow inside the thrombus. This is the phenography. Lastly, I came to the conclusion. Budd-Chiari syndrome, there are the diagnosis aims at establishing the diagnosis of Parker syndrome, establishing the detailed anatomy of the hepatic veins and the IBC, follow-up of patients after treatment. Interventional radiology aims at restoring of the hepatic venous outflow. Veino-occlusive disease, new imaging have no role, only to exclude other cause of liver disease, and the diagnosis based mainly in liver pathology. Hepatic hemangioma, the imaging is to establish the diagnosis and to differentiate hemangioma from other focal lesions, particularly HCC, portal vein thrombosis. The aim of the imaging model to establish the diagnosis and to differentiate benign from malignant thrombus. Thank you.
نشكر الدكتور طلال على المحاضرة الأكاديمية الجميلة الشبه متكاملة. هو كان سبوست الدكتور أسامة شحة بس ظهر عنده ظروف في القاهرة ما قدرش يجي، فكده احنا هنقفل السيشن الأولانية في بريك بسيط كده، في شاي ونسكافيه بره وناخد ريست شويه، وبعدين عايزين ناخد صوره جماعيه قبل ما انتوا تزهقوا وتمشوا ان شاء الله. بعد كده ان شاء الله السيشن الثانيه هنبدا بالاستاذ الدكتور ايمان عمر. بره شاي ونسكافيه بره. بعد البريك بقى ناخد صوره.